joining. If you're joining from a different time zone, good evening to you, good morning to us in India and in the south of global south and so forth. So first of all, thanks to the Kotak IISc Center as well as my organization TANUH, along with it the folks from University of New South Wales and IISc for this joint workshop, which we called AI for healthcare in the grassroots. So primarily, I am kickstarting. I have the privilege of kickstarting this online workshop. So the format that we have, just a reminder for the rest of the audience, is that we will have presentations which are lasting about 10 minutes, and I will try my best to keep my own time in check to meet the 10-minute boundaries. And the way the talks have been structured is that at the end of about 9 of these talks, which roughly represents to about 90 minutes of presentation, we will have about 30 minutes of question answering. So what we will request all the audience is to keep their microphone and other questions in check and can be raised during this last 30 minutes of the presentation, where the floor will be open for questions according to all the talks. Right. So with that little caveat, let me slowly get started. So this is basically the first one that I was asked to present in this online workshop was an introduction to the initiative that we have in IISc on the AI for healthcare. So this is jointly put together with Professor Phanindra Elavarthi, who is also going to give a talk later, and myself. And we have a team of about 9 core faculty members along with several employees at TANUH who have helped together some of these initiatives that I'm going to talk about. Right. So where are we and what is the the ecosystem that is providing an opportunity for AI centers of excellence like this from the government of India. So this is basically the larger picture where AI centers of excellence in various subdomains of importance for the national initiative had been launched from the government, starting from agriculture, then to smart cities and sustainable cities. And we at Indian Institute of Science, Bangalore, have been mandated with the healthcare initiative. And more recently, IIT Madras, which is another lead university in the country, has been awarded the AI Center of Excellence in Education. So these nodal hubs, which universities are going to primarily act as the central locations to coordinate the activities on this AI Center of Excellence. And as listed in this particular slide, they have particular sub-mandates on education, on sustainable cities, and healthcare and agriculture. So in particular, on our side, on the healthcare, the IISc Bangalore's focus has been on the non-communicable diseases or NCDs. So what are these AI centers of excellence? Let me just provide a quick word on it if you're not aware of it. So these AI centers of excellence, primarily their role is to focus on development and deployment of software as a medical device, SAMDs. So in particular for this healthcare initiative, we are not going to have hardware developments. These are going to be device agnostic developments. Part of the reason to envision this is that at a grassroots level, at a scalable level, having hardware dependency and having other dependencies is only going to slow the speed of outreach across the length and breadth of the country. So the other focus on this AI Center of Excellence is going to be on the deployment, on the translation of AI. So in fact, the name TANUH itself is Translational AI for Network Universal Healthcare. So these are projects that are aimed to be completely translational in nature. A research, a development has to go hand in hand with the deployment and the outreach of this technology for the grassroots. So a caveat and a disclaimer that various other prior studies have reported is that healthcare AI projects tend to have a significant high bar. Some of it we are also going to talk about in my subsequent presentation too. That most of them actually fail when they try to transfer from the lab to the verification or validation in regulatory settings and then eventually in the deployment setting. So we are trying to see how we can bridge that gap between research, development, and deployment. Then the other question I wanted to also take off at the beginning itself, which is on the choice of working on NCDs or non-communicable diseases. So this is not only just a story in India, but across the world. If you take a situation, say about 30 years ago to right now, the major contributor to early deaths and fatalities is the NCDs. From moving from epidemiological concerns, the lifestyle-based diseases, the non-communicable diseases that are prevalent across the globe, and in particular in India, you see that cardiovascular as well as chronic respiratory diabetes and CKD, they all have become the top contributors to all age deaths. Right? And then many of them are preventable with early intervention, with early screening choices that we can make, as well as various lifestyle and diet considerations we can put in place. So where are we trying to push this in, right? So if you take a continuum of care, this is largely an India-centric scenario, but it also is valid perhaps in many other economies and global societies, where a set of people who want to seek healthcare enter the health system through a primary health setting. This is the first point of care where I have listed it as arrival at the point of care, and then some initial preliminary diagnosis is done. This could not necessarily involve specialists or top-notch clinicians. This could be general practitioners or nurses, or in our case in India, these are the ASHA workers. And subsequently, if a primary diagnosis is indicative of a risk, they are pushed up in the health chain for a long-term disease management and further diagnostics. So now the rightmost part, what we feel is one of the important places for AI to come in and take a significant role is in the arrival at the first point of care. So AI solutions at this location has the widest outreach, but also, as I remark in the subsequent slide, the gap in the skill level and the requirement at that level is the highest. So in the case of India, these are non-physician health workers or NPHWs. So they particularly do not have a medical or a clinical training from a education point of view, but although they go through some level of training before they undertake this primary health situation, but they are not medically, let us say, a degree holders. So in that setting, in addition to the skill gap, there is also the gap that they have to attend to a large number of population. So about typically these ratios in the country are about 1 in 1,000 for NPHWs. So these resource constraints, the ability to scale up significantly and to cater to a large volume of patients that are coming in, then is where we find the AI to have the largest outreach. So at TANUH, just quickly walking through various steps since we have only about a couple of more minutes in this talk. So we are trying to walk the entire ladder. This involves ethical compliance, requiring all our protocols and designs to be ethically and medically valid. Involves once the AI models are ready to have a regulatory approval, have to have practical applicability in terms of lightweight and in terms of scalability. We cannot serve very large size models to populations in millions. And in other setting, we also are looking for enterprise level platform so that all the UI, the software, the backend is strong to support a healthcare app outreach. So very quickly, some of these also become topics of our discussion later in our workshop. So the five key verticals in which TANUH is going to focus on, this includes oral cancer. We will hear more about oral cancer vertical from Professor Rajesh Sundaresan. Breast cancer, which is also again AI tools for enabling early diagnosis. This is also led by Professor Panindra, who is also going to be part of our speaker panel. Retinal care and diabetic management, these are other. And the last one is the mental health, where I am primarily taking charge of the vertical. So just to remind everybody again, the whole roadmap consists of forming these protocols, designing studies, collecting data at the grassroots levels, developing models for the solutions that we want, where we can augment. And these solutions are also going to be an AI model in assistance with the existing workflow. They're not planning to replace any workflow. They're not planning to substitute or automate anything directly. They are going to improve the efficiency of the existing healthcare system. Right? Once these models are developed, they have to go through regulatory approval, and this is in the countries, the Drug Controller General of India, the DCGI, but in various places, like in the US, for example, this is the equivalent of the FDA. Right? Once the validation and certification are obtained that these meet the regulatory requirements, then we also have to deploy it as a digital public infrastructure. Essentially, this means that a solution or app is out there which can access these models, which can provide the service to these models. Right? My last slide on this is to provide a unified view of how we think of the AI roadmap. And the AI roadmap essentially consists of an interaction which could have an audio component or a voice component, could have imaging components. Some verticals have images also recorded. In addition to it, the healthcare records, the metadata, the patient current conditions, past medication history, family history, all those are what we call as a tabular health record data. The way we envision this model is to combine the information that cuts across all these modalities, put them all together into a medically aware large language model, and it can provide you advice, documentation. In addition to it, it can also provide supervisory signals for treatment suggestions. Okay, so that is pretty much what I had, and various verticals are at various locations in this chain. So we are almost starting it with mental health, breast cancer, and so forth. But some of them, like oral cancer, have reached significant levels up to the regulatory approvals. So thank you again. I think I overshot by a couple of minutes. We started about 3 to 4 minutes late. So thank you again for your attention. More details are available here, and happy to take questions during our Q&A session.